A 74-year-old man named Arthur came to me 20 months ago. He was a retired civil engineer. Methodical, organized. The kind of man who kept a spreadsheet of his monthly expenses and a written log of every medical appointment he had attended in the past decade. He brought that log to our first meeting. 14 appointments in 2 years. 4 different doctors, a cardiologist, a rheumatologist, his GP, an endocrinologist. All of them had seen him. All of them had reviewed his conditions. All of them had prescribed him something. Arthur was taking 11 medications. 11. He had a morning pill organizer and an evening pill organizer, and a third one he carried in his jacket pocket for the medication he took with lunch. He had never been told which of those 11 medications could not safely share space in his body at the same time. He had never been told what happened when 2 of them were taken together, not because the doctors did not know, because in 14 appointments across 4 different practices, not one of them had seen the complete picture. Each doctor had seen their piece of it. Nobody had seen the whole thing. 6 weeks before Arthur came to me, he had been found on his kitchen floor by his wife at 7 in the morning. He had no memory of falling. He had no memory of the 30 minutes before he was found. His wife had called an ambulance. He had been assessed, found to have no fractures, and discharged with a note suggesting his blood pressure may have dropped and he should stay hydrated. Nobody at that hospital reviewed his full medication list in the context of drug interactions. He was home by afternoon. His wife told me later that she had cried in the car on the way back because she knew something important had been missed and did not know what it was. When I sat down with Arthur and went through his 11 medications one by one, I found 3 dangerous combinations. 3 pairs of drugs that were interacting inside his body in ways that were measurable, documented, and in one case directly responsible for the episode that had put him on his kitchen floor. None of those combinations were accidents. None of them were reckless prescribing. They were the predictable consequence of excellent specialists treating individual conditions in isolation without a single person responsible for seeing the whole picture. I'm Dr. Kevin Adewale. I'm a cardiothoracic surgeon. I've spent over 30 years operating on hearts, repairing arteries, and watching what happens when the medications that are supposed to protect people begin to work against each other inside the body. What I'm about to share with you, most doctors won't bring up at your annual checkup, but after 50, it matters more than you think. Today, I'm going to walk you through 6 of the most dangerous medication combinations that adults over 50 encounter, minus combinations that are not rare, not exotic, and not the result of unusual prescribing. They are common. They are happening in millions of homes right now, and most of the people experiencing them have no idea. Stay with me, because the combination I describe in the middle of this video is the one I see most frequently in patients who end up on my operating table, and it is the one that almost nobody checks for. Before I take you through the 6 combinations, I need you to understand something about medication interactions after 50 that most people have never been clearly explained. Because without this understanding, the specific combinations I'm about to describe will not make full sense. And with it, they will make complete sense. And you will know exactly what to do about them. Think of it this way. Your body processes medications the way a city processes traffic. When there is 1 car on the road, it moves freely. When there are 2 cars, they manage. When there are 5, 10, 11 vehicles all moving through the same intersections at the same time, competing for the same routes, affecting each other's speed, sometimes blocking each other entirely, the system does not work the way it was designed to. Drugs are processed primarily through 2 systems in the body: the liver, which metabolizes them, and the kidneys, which excrete them. After 50, both of those systems slow down. The liver's enzyme activity decreases. The kidney's filtration rate drops by approximately 1% per year after the age of 40. That means a 70-year-old's kidneys are filtering at roughly 70% of the capacity they had at 40. Drugs stay in the body longer. They accumulate. And when multiple drugs are competing for the same metabolic pathways in a system that is already running at reduced capacity, the interactions become unpredictable, amplified, and dangerous in ways that simply do not occur in younger bodies. The American Geriatric Society estimates that adverse drug interactions are responsible for approximately 30% of all hospital admissions in adults over 65. 30%. Nearly 1 in 3. Not infections, not falls, not cardiac events, medications interacting with each other inside the bodies of people who are trying to protect their health. That number is not declining. It is rising as the number of medications prescribed per patient increases. The average American over 65 takes more than 5 prescription medications simultaneously. Many take significantly more, and the probability of a significant drug interaction increases exponentially with each additional medication added to that list. What you do with the information in the next several minutes either puts you in a position to have the right conversation with your doctor or leaves you and the people you care about unprotected. Let me show you exactly what I mean. The first dangerous combination is one of the most common and one of the least discussed. Blood thinners taken together with common over-the-counter pain relievers. Specifically, anticoagulant medications, warfarin, apixaban, rivaroxaban, or any medication prescribed to prevent blood clots taken at the same time as non-steroidal anti-inflammatory drugs. NSAIDs, ibuprofen, naproxen. The medication sold in every pharmacy and every supermarket under names like Advil, Motrin, Aleve, and dozens of others. Here is why this combination is so consistently overlooked. NSAIDs feel like they belong in a different category from prescription medications. They are over-the-counter. They are familiar. They have been used for decades. The person taking a blood thinner for atrial fibrillation or for a mechanical heart valve reaches for ibuprofen when their knee hurts because they have always reached for ibuprofen when their knee hurts. It does not feel like taking a medication. It feels like taking a painkiller. The distinction feels irrelevant. It is not irrelevant. It is potentially fatal. Here is what nobody tells you. NSAIDs affect the blood in 2 ways simultaneously that are both dangerous in someone taking an anticoagulant. First, NSAIDs inhibit platelet function. They impair the platelet's ability to clump together and form a clot. In someone whose blood is already being thinned by an anticoagulant, adding a platelet inhibitor creates a compounding anti-clotting effect. The blood becomes far less capable of forming a clot than either drug alone would produce. Second, NSAIDs damage the lining of the stomach and the upper gastrointestinal tract. They inhibit the prostaglandins that protect the stomach wall. They create microscopic erosions and ulcers in a stomach that is already being bathed in anticoagulated blood. The result is gastrointestinal bleeding that the body cannot stop because the blood is being stripped of its ability to clot from 2 directions simultaneously. Here's what is actually happening inside your body. The anticoagulant has already shifted your INR, your clotting time, to a therapeutic range designed to prevent dangerous clots. That range has almost no buffer for an additional anti-clotting agent. When an NSAID is added, the effective anticoagulation can shift dramatically above the therapeutic range. Internal bleeding that would normally be self-limiting becomes profuse. Gastrointestinal hemorrhage, intracranial hemorrhage in the most severe cases, a brain that cannot stop bleeding because the blood is being made incapable of stopping itself by 2 drugs that were never meant to be taken simultaneously. Research published in JAMA Internal Medicine found that adults over 65 taking anticoagulants who used NSAIDs, even for short periods, had a significantly elevated risk of serious bleeding events requiring hospitalization compared to those taking anticoagulants without NSAID use. The risk was not theoretical. It was measured in emergency admissions, in blood transfusions, in deaths. If you take any blood thinner, write this on a piece of paper and put it in your wallet right now. No ibuprofen, no naproxen, no aspirin. unless specifically prescribed by the doctor who manages your anticoagulation. For pain relief, paracetamol acetaminophen is significantly safer for most people on anticoagulants. But have that specific conversation with your prescribing doctor before making any change. The second dangerous combination is one that I see with troubling frequency and one that has a very specific and very serious cardiac consequence. ACE inhibitors or ARBs taken together with potassium supplements or potassium-sparing diuretics. Let me be specific. ACE inhibitors are medications like lisinopril, ramipril, and enalapril among the most commonly prescribed blood pressure and heart failure medications in the world. ARBs include losartan, valsartan, and candesartan. Both classes of medication cause the body to retain potassium. They do it as part of their mechanism. When a potassium supplement is added on top, or when a potassium-sparing diuretic, like spironolactone, is prescribed alongside them, potassium levels in the blood can rise to levels that are genuinely dangerous. Here is why people do not connect this. Potassium supplements are sold over the counter. They are natural. They are associated with heart health. Everyone has heard that bananas are good for the heart because of potassium. The word potassium does not sound like a risk. It sounds like a nutrient. And in a body with normal kidney function and no ACE inhibitor on board, potassium supplementation is generally benign. But in a body already retaining potassium through an ACE inhibitor and filtering it less efficiently through kidneys that are 70% functional, potassium accumulates. And elevated potassium hyperkalemia is directly cardiotoxic. Here is what is actually happening inside your body. Potassium is the primary electrolyte responsible for maintaining the electrical potential across cardiac cell membranes. The heart's rhythm depends on a precise and tightly regulated potassium gradient. When potassium rises above 5.5 millimoles per liter, the electrical behavior of cardiac cells begins to change. The heart's rhythm becomes unstable. At 6.0 millimoles per liter, life-threatening arrhythmias become a real risk. At 7.0 and above, cardiac arrest is possible. Hyperkalemia kills quietly. There is no dramatic symptom in the early stages. There may be mild muscle weakness. There may be nothing at all. The first sign can be a cardiac monitor showing a waveform. That tells a cardiologist something catastrophic is imminent. A study published in the New England Journal of Medicine confirmed that the combination of ACE inhibitors with potassium-sparing diuretics significantly increased the rate of hyperkalemia-related hospitalizations and deaths in elderly patients compared to those on ACE inhibitors alone. The potassium was being retained from two directions simultaneously. The kidneys could not keep pace. The heart bore the consequence. So if you take an ACE inhibitor or an ARB, do not add any potassium supplement without first having your blood potassium level checked and discussing it explicitly with your prescribing doctor. And if you are prescribed spironolactone or any potassium-sparing diuretic while already on one of these medications, ask your doctor directly what monitoring schedule is in place to catch potassium accumulation before it reaches cardiac risk levels. But the next combination is where things become far more serious, and is the one I see most frequently in patients who end up requiring cardiac intervention. The third dangerous combination is the one that surprises almost every patient I tell it to. Not because the drugs are unusual, but because they are so ordinary, so universally prescribed, so completely expected to be taken together in the population that needs them most. Statins combined with certain antibiotics or antifungal medications. Specifically, statins, atorvastatin, simvastatin, lovastatin combined with clarithromycin, erythromycin, or fluconazole. Here is why this combination is missed so consistently. A statin is a long-term medication. It sits in the morning pill organizer. It is taken every day without variation. When a patient develops a chest infection and is prescribed clarithromycin by their GP, nobody in that consultation connects the antibiotic to the statin. The GP is treating an infection. The cardiologist prescribed the statin months ago and is not in the room. The patient takes both, and something dangerous begins. Here's what nobody explains clearly enough. Statins are metabolized in the liver by an enzyme system called the cytochrome P450 pathway, specifically the CYP3A4 enzyme. Clarithromycin, erythromycin, and certain antifungal medications are powerful inhibitors of that same enzyme. When you take a CYP3A4 inhibitor alongside a statin that depends on CYP3A4 for its metabolism, the statin cannot be broken down at its normal rate. It accumulates in the bloodstream. Statin levels rise dramatically, sometimes to 5 or 10 times their intended concentration. And at those concentrations, statins become toxic to muscle tissue. Here is what is actually happening inside your body. The condition is called rhabdomyolysis, the breakdown of muscle tissue. At elevated statin concentrations, the drug begins to damage the membranes of muscle cells throughout the body. Those cells release a protein called myoglobin into the bloodstream. Myoglobin travels to the kidneys, and myoglobin in the renal tubules at high concentrations is directly toxic to kidney tissue. It causes acute kidney injury. The same kidneys that are already filtering at reduced efficiency after 50, the same kidneys that cannot excrete the accumulating statin rapidly enough to prevent further damage. The cycle accelerates. Muscle pain is often the first symptom, but the muscle pain of rhabdomyolysis is different. It is severe, it is generalized, and the urine can turn brown or tea-colored as myoglobin spills through the kidneys. Research from the British Journal of Clinical Pharmacology documented significantly elevated rates of statin-induced myopathy and acute kidney injury in patients who were co-prescribed CYP3A4 inhibiting antibiotics alongside high-dose statins, with the highest risk concentrated in adults over 65 whose reduced kidney function allowed statin accumulation to proceed unchecked. If you take a statin, tell every prescribing doctor you see, including your GP, including any urgent care provider, including any dentist prescribing antibiotics, that you are on a statin, and ask them to verify there is no CYP3A4 interaction with whatever they are about to prescribe. That single question takes 10 seconds and can prevent a hospitalization. Tell me in the comments, are you currently on a statin, and has any prescribing doctor ever asked you about drug interactions before adding a new medication to your list? I want to understand how many people watching this have never been asked that question, because that answer tells me something important about the gap this video needs to fill. The fourth dangerous combination involves a class of medications that most people over 50 have been told they need, and a common supplement that most people over 50 believe is harmless. Levothyroxine, the thyroid medication taken by millions of adults for underactive thyroid, combined with calcium supplements, iron supplements, or antacids containing calcium or magnesium. Here is why this is so deeply embedded as a problem. Thyroid medication requires a very specific relationship with timing and absorption. Levothyroxine is one of the most precisely dosed medications in existence. The difference between adequate and inadequate thyroid control can be as little as 12.5 micrograms. And calcium, iron, and certain antacids chemically bind to levothyroxine in the gut and prevent it from being absorbed. The medication passes through without reaching the bloodstream. The thyroid remains under-replaced, and the person continues to experience fatigue, weight gain, cognitive fog, and cold intolerance that their doctor attributes to inadequate dosing, and responds by increasing the dose when the actual problem is that the dose they were already taking was being neutralized by the supplements they were taking alongside. Here is what is actually happening inside your body. Levothyroxine is absorbed in the small intestine. Its absorption depends on a specific gut environment and is highly sensitive to the presence of other compounds that bind to it. Calcium ions and iron ions form insoluble complexes with levothyroxine in the gut lumen. Those complexes cannot cross the intestinal wall into the bloodstream. They are excreted. The thyroid hormone never reaches the circulation. The TSH rises because the pituitary detects insufficient thyroid hormone and signals for more. The patient's numbers suggest they are under-medicated. Their dose is increased. They begin experiencing the subtle symptoms of over-replacement on the days they happen to take the medications further apart. The picture becomes confusing. The actual solution, separating the medications by at least 4 hours precisely, was never discussed. Research published in Thyroid found that concurrent calcium and levothyroxine administration reduced levothyroxine absorption by up to 40%. 40%, nearly half the medication, gone before it ever reached the bloodstream. In a medication where 12.5 micrograms is a meaningful dose adjustment, losing 40% of absorption is not a minor pharmacological inconvenience. It is clinical failure of the medication being treated as a dosing problem. If you take levothyroxine, it must be taken on an empty stomach, typically first thing in the morning, with nothing else for at least 30 to 60 minutes. No coffee, no calcium supplement, no iron tablet, no antacid, nothing. And if you have been struggling to get your thyroid numbers stable despite dose adjustments, bring your complete supplement and medication list to your next endocrinology or GP appointment and ask specifically whether timing interactions are contributing to the instability. The fifth dangerous combination is one that operates through the nervous system and produces an effect that is both dangerous and deeply misunderstood. SSRIs, antidepressants like sertraline, fluoxetine, citalopram, and escitalopram, combined with tramadol, which is a commonly prescribed pain medication for arthritis, back pain, and post-surgical recovery in adults over 50. Here is why this combination slips through. Depression and chronic pain frequently coexist in older adults. They are often managed by different doctors. The psychiatrist or GP managing depression prescribes an SSRI. The orthopedic surgeon or pain specialist prescribes tramadol for joint pain. Neither may be fully aware of what the other has prescribed. The patient takes both, and a syndrome begins developing that, with full visibility of what the other had prescribed. Both medications working as intended in isolation, together, producing a heart rate low enough that his blood pressure dropped, his cerebral perfusion fell, and he lost consciousness on his kitchen floor at 7 in the morning. Research from the European Heart Journal confirmed that the co-prescription of beta blockers with non-dihydropyridine calcium channel blockers in elderly patients was associated with a significantly elevated risk of symptomatic bradycardia, syncope, and hemodynamic instability requiring hospitalization, with risk concentrated most heavily in adults over 70 with pre-existing conduction abnormalities. The warning is in the cardiology literature. It is in the prescribing guidelines. It is not consistently making it into the conversation at the point of prescribing. If you take a beta blocker, know which type of calcium channel blocker you have been prescribed. Amlodipine and felodipine, the dihydropyridine class, carry significantly lower interaction risk with beta blockers and are generally considered safe in combination when clinically indicated. Verapamil and diltiazem are the drugs to flag. If you take a beta blocker and have been prescribed either of those two, ask your cardiologist specifically whether that combination has been reviewed for your heart's conduction status. Let me bring all 6 together. Blood thinners with NSAIDs. The anticoagulation becomes unpredictable and internal bleeding becomes difficult or impossible for the body to stop. ACE inhibitors or ARBs with potassium supplements or potassium sparing. Diuretics. Potassium accumulates silently to levels that destabilize the heart's electrical system. Statins with CYP3A4, inhibiting antibiotics or antifungals. The statin accumulates to toxic concentrations that destroy muscle tissue and damage the kidneys, processing the debris. Levothyroxine with calcium, iron, or antacids. Up to 40% of the thyroid medication is chemically neutralized in the gut before it ever reaches the bloodstream. SSRIs with tramadol or other serotonergic pain medications, serotonin activity rises to dangerous levels, producing a syndrome that can progress from agitation to multi-organ failure within hours. And beta blockers with verapamil or diltiazem, the heart rate and conduction are slowed from two directions simultaneously, producing the kind of bradycardia and syncope that puts people on their kitchen floors and sends families to hospital waiting rooms. 6 combinations, none of them rare, none of them exotic, all of them preventable with one thing: a complete, unified medication review by someone who can see the whole picture at the same time. Knowledge without action is just worry, and I am not here to make you anxious. I am here to give you a plan. I call this the Medication Safety Protocol. 5 steps, starting this week. Step 1. Write a complete medication list. Every prescription medication, every over-the-counter medication taken regularly, every supplement including vitamins, minerals, fish oil, herbal products, and anything else taken daily or frequently. Write the name, the dose, and the prescribing doctor for each. One list, one piece of paper, or one document on your phone. Carry it with you to every medical appointment from this day forward. Step 2. Request a medication review appointment with your GP specifically, not as part of another appointment, but as a dedicated appointment for reviewing your complete medication list for interactions. In the UK, your GP practice is required to offer medication reviews. In the US, many practices offer them, and a clinical pharmacist attached to a primary care practice is often the most knowledgeable resource for this purpose. Ask specifically for medication interaction review. Step 3. At every new prescription, before you leave the room, ask this exact question: does this interact with anything else I am currently taking? Every time, without exception. It takes 10 seconds. The discomfort of asking is far smaller than the consequence of not asking. Step 4. If you take any of the high-risk medications mentioned today, anticoagulants, ACE inhibitors, ARBs, statins, levothyroxine, SSRIs, beta blockers, verapamil, diltiazem, flag them explicitly to every new prescribing doctor and every pharmacist dispensing a new medication. Do not assume they have your complete record, assume they have a partial record, because in most healthcare systems, they do. Step 5. Use your pharmacist as a medication safety resource. A community pharmacist has access to your dispensing history and is trained specifically in drug interactions. If you are uncertain about a combination, ask your pharmacist before you take the new medication home. That conversation costs nothing and can catch what 4 specialist appointments missed. I want to come back to Arthur. After his complete medication list was reviewed and the 3 dangerous combinations were identified, his medications were restructured in collaboration with all 4 of his prescribing doctors. The diltiazem was switched to amlodipine, a calcium channel blocker with a much safer interaction profile alongside his beta blocker. His potassium supplement was stopped and his potassium level was monitored. His pain management was reviewed, and ibuprofen was replaced with paracetamol and a topical anti-inflammatory that did not carry systemic bleeding risk. 3 months later, he came back to see me. He had not fallen. His heart rate was stable. His energy was better than it had been in a year. He sat across from me and put his medication log on the desk, still kept, in the same precise format as always. And he said the words I have heard from patients more times than I can count in 30 years of this work. He said, 4 doctors, 14 appointments, nobody sat down and looked at the whole list. At the same time, nobody... He paused, then he said, I nearly died on my kitchen floor because nobody looked at the whole list. That conversation has stayed with me ever since. It is a significant part of why I make these videos, because the information exists. The research exists. The warnings are in the prescribing guidelines. But somewhere between the specialist appointment and the kitchen counter where the pill organizer sits, that information gets lost. You are standing at that kitchen counter right now, and you now know what to look for. Which of these 6 combinations is sitting in your medication list right now? Which one did you not know about before you watched this video? Tell me in the comments below. I read every single one, and your answers tell me what the conversation around medication safety in adults over 50 is still failing to cover. If this video gave you something that changes what happens at your next doctor's appointment, share it. Not for me, for the person in your life who is taking 11 medications managed by 4 different doctors with no single person responsible for seeing the whole picture, who has been told each prescription is correct without anyone checking what happens when all of them are taken together. Who is doing everything they have been told and does not know that 2 of those things should never be done simultaneously. They may not know, but you do now. And that is exactly why you are here. And if you have not subscribed yet, please do. Every week I bring you honest, evidence-based information that I wish every one of my patients had access to long before they needed surgery. Take care of your heart. It has been working for you every single minute of every single day without asking for anything in return. Give it what it needs. It is a fair trade. One last thing. And this is important. Everything I have shared today is general medical information based on published research and my clinical experience as a cardiac surgeon. It is not a substitute for your personal medical care. Please do not stop or change any medication on the basis of this video without speaking to your own physician first. They know your history, they know your individual clinical picture. I do not. This is education. Use it as the beginning of a conversation. The conversation that Arthur wished he had started 14 appointments earlier.